everyone. I am really happy to have the opportunity to speak to you today, and want to thank Mark and Tristan, who do so much work to make this happen. I'm very grateful for that. This is something that probably everyone here could teach a piece of, and it is a very broad, in-depth topic. And please know I am going through, probably every slide could be its own presentation. So if I don't give full attention to a topic that you would like me to discuss more, please be aware, I know that. There's so much information I want to share with you, and take advantage of this opportunity. So my name is Sherri Wittwer. I have worked in the mental health system in a variety of capacities, not as a clinician, but as more on the policy and advocacy side, and helping to build programs and services and housing for people with serious mental illness. I am a family member of someone who has serious mental illness, and I know the heartache that causes families. And I also, as I talk about this, work with a number of clinicians and physicians who are wonderful. And in sharing this journey, I in no way want to diminish the contributions of truly caring providers who care about this population and do outstanding work. But as we are talking about this, we need to listen to the people who are personally affected. And that is something we just don't do enough in our system at all. So a couple years ago, I decided I was going to be somewhat retired and work on more of the projects I wanted to, which is a wonderful place of privilege to be, to say, you know, there are things I want to work on within mental health and outside of mental health. And during that time, I had people with lived experience with mental illness come to me and say, Sherri, our voice isn't being heard. We are not being represented. We need to have an organization that is run by us, driven by us, that we are pushing. And I listened to them, and you know what? I've learned a lot. I've been humbled a lot. And I said, you're right. We need to make that happen. So we have been in the process of helping to build a peer-run organization, Mental Health America of Utah. It's brand new. And we're working on that. But where we are right now is at a tipping point, and we're talking a lot about individual rights. And there are a lot of groups who are rightfully very concerned. But there has also been an effort for years now that has been slowly happening where the rights of individuals with mental illness are slowly being encroached upon. And I want to talk about that. I don't have all the answers. Many of you will know a lot more and have some great ideas. I hope to give you time to help share those. But I think it's important to know that a lot of why we are where we are is because we've made choices along the way. It's not by accident. So let's get into it. When we talk about mental illness, we're talking about health conditions that involve changes in emotion, thinking, or behavior. Now, all of us are aware of our mental health, and there's been a lot that has been done to destigmatize mental illness. We all know that our mental health is on a continuum. You have good days, bad days. We notice anxiety, depression in ourselves. But just like physical health, there are times when it can get away from us, when there are more serious conditions, more chronic conditions that require more specialized care as well. Now, mental health conditions are not the result of any one event. There's a different combination of genetics, environment, and lifestyle can influence that. Traumatic life events, that's something that we've really just started talking about recently, which makes all the sense in the world that if you have trauma, unresolved trauma, that is going to impact your mental health. So mental illness can affect anyone, any age, race, religion, income, and they can't be overcome just through willpower and it's not about a person's character or intelligence. These are treatable illnesses, and again, the success of treatment depends on whether or not you're able to access it, your family support. That's what I think about all the time is if the people that I love did not have family support, where would they be? And so there's a lot to be said for the different components that can improve outcomes. So how many are affected? We know that 1 in 5 adults experience mental illness, 1 in 20 experience serious mental illness, and half of all lifetime cases of serious mental illness or of mental illness are in place by age 24. So the earlier we can intervene, the better. Now, with COVID, it's brought mental illness out into the forefront. We know this, that, we're all recognizing, wow, I am not doing well with this isolation or this fear, everything that's happening. And in a way, it's been good to help people understand, because there are people who've never really understood mental health who are, okay, I get it now. I see how dangerous this can be. So it's something that we need to address. And without treatment, the consequences of mental illness for the individual and our society are staggering. It can lead to unnecessary disability, school dropout, unemployment, substance use, poor physical health, homelessness, inappropriate incarceration, suicide, and overall poor quality of life. And there's a huge financial cost of this to society. Now, we've made really great progress, and this is where the tipping point is, in that we're talking more about it. I mean, when I started in this work, I remember thinking, if we could just get one celebrity who would come out and talk about their issues. Now we have so many, right? And we're more willing to talk about it. We're more willing to have those discussions. We are trying to destigmatize the whole use of crisis lines and warm lines. We have an app for kids and adults in Utah. And that's great. So on one hand, we're saying, look, don't be afraid. Please seek help. On the other hand, the pendulum has really been swinging for a few years now, where as a system, we are becoming more punitive. There's more of a use of a hammer in dealing with people with mental illness. We tend to blame the person, and I'll go and explain all of this, but we blame the person for a failed system, for a system that we know does not work. We are putting the responsibility on the individual who is suffering. There is a lot of effort being made on involuntary commitment and tracking people. There are privacy concerns. And every time there is a horrific mass shooting, which we have way too often, way too much, the first thing that comes out of some politicians' mouths is, well, we've got to address mental illness. Now, yes, we need to address mental illness. The only time they talk about that is in that context, whether or not they know the person has a mental illness or not. And nothing ever comes of that either. Not only does nothing ever come with gun reform, nothing ever comes from true reform with mental illness or our systems. So it's hard to destigmatize and at the same time be placing blame for horrific tragedies on a population that really does not necessarily have a great voice. To that end, I've invited my friend Venis Weaver to come up. Venis she's a rock star, and I want her to take a few minutes and tell her story.
Hello, like Sherri said, my name is Venis, and I have a mental illness, and I have been working towards getting my master's in social work, and it's very interesting in doing this because I was diagnosed with a mental illness when I was in high school. I ended up spending about let's say I ended up at the state hospital when I was in high school. My mother had committed suicide and was in another state when it happened, and that triggered my mental illness. And in that, I lived in Carbon County, where there are very few resources. And I ended up at the state hospital because there is no resources in Carbon County for the mentally ill. And so I was there for about a year, and when I came out and went back home, there was very little support because of the resources that are not available. And I wanted to better my life. I wanted to not live in that stigma of mentally ill. But I was in and out of the hospital a lot. And I just couldn't, I couldn't keep it together because there was no resources. And so I ended up moving to Salt Lake. And when I moved here, there were so many more opportunities, so many more things that I could be a part of to help my mental illness and to give me the opportunity to grow and to be a part of the community. But the obstacle of it is I am on medication that I can only get at certain pharmacies. I can only do so much with it because I am wanting to work. I'm getting my master's in social work right now, and I am working on moving forward, and I've been working as a peer advocate, and as a peer advocate, I've been working with clients and people who are in similar situations that I was in. And yet, I'm not able to move to the next step of getting my master's degree without the support of the peers. I'm sorry, I'm just all garbled today, but I want to work. I want to put in an honest day's work, but I can't, because if I do, then I lose my Medicaid. If I lose my Medicaid, I lose my meds. My medication cannot be obtained through regular insurance. The insurance only covers my the only insurance that covers my medication is Medicaid. And in order to get the Medicaid, I cannot work so many hours and I cannot earn so much money. So they say that people on assistance are lazy and they just don't want to do anything and they're just doing a free ride, which is not true. I would work more hours. I would work, I would work more. But the problem is that if I work more, then I earn more money and then I get booted off Medicaid and then I lose my meds and I can't work. I'm like, it's just, it's a quandrum that you have an opportunity to better yourself and, move on, but at the same time, you can't because of the restrictions. And we're hoping to bring more peers to the table and put them in more of the decision-making processes. And, institutionalizing people doesn't help the problems. Institutionalizing just makes it worse because people aren't learning the skills they need to be in the community. So, thank you.
Thank you, Venis. So Venis works part-time. She's in graduate school. She's just has picked up a few more hours for our new organization to be doing outreach with individuals experiencing homelessness. And I am just, Venis's story illustrates one of the many barriers that people have who are capable and able and want to move forward with their lives, but there are things that are out of their control. As I've talked to other peers who have been approaching me, what they've explained has been a crisis of trust with the system. And if you don't trust the system, it's very hard to want to access services and resources. There's a problematic history of treatments. We'll talk a little bit about that and the efficacy of them. That people affected by mental illness are too often seen as subhuman. I mean, my rule of thumb in my advocacy work is, would this be something I would want? Would this be something I would want my child to have? If the answers to those are no, then we need to do better. We need to reach higher. And too often it is, well, it's better than this. Well, we need to raise the bar on what we're trying to do. People affected by mental illness are too often not even consulted about their own treatment, or they're forced into treatment. So we've built some impressive crisis supports, but I've been concerned as I've had people with lived experience say to me, you're building services I would never access, and here's why. That's a real concern when the very people who need it the most are the ones saying, I would not call that, and I have concerns about that. And the only way we learn that is by having them at the table when we're building these systems and we're I mean, we have a very patriarchal approach in how we work with people with lived experience, saying, no, this is what you need. No, I think this is how you should do it, instead of having them at the table to help develop that. So, this is a problem. And I thought of many titles for this slide, and I thought, I'm just going to call it a problem. But really, it's this bell curve of normalcy that we cling to. And the fact that it really is a bell curve that's been developed by patriarchal systems. White, straight males have developed most of our systems, if not all. And that's true with the practice of psychiatry and within our mental health systems, that everything is based on coming from that perspective. So, where are the history of mental illness, and I just want to go through this briefly because it's important as to why we are here. Dorothea Dix was a mental health advocate. She was also a Unitarian, I might add. And she promoted humane treatment of people with mental illness. She saw how they were being treated in prisons and said, we need to develop safe places for them. Her intent was really good and wholesome, and at the time really did relieve a lot of sadness and inhumane treatment of people. Of course, no good thing cannot be, and I'm not even saying that was, at the time that was good and it provided solace, but then it was used as a way to round up people and to put people in places. There was a federally run state hospital in South Dakota. They went in and said, you know what? We need this industry, bring jobs to our place, and we've got these pesky people we need to round up and get out of the way. And so it was a facility specifically for Native and Indigenous people. After the Civil War, there was a whole lot of discussion about how African Americans, Black people, were dependent on slavery to succeed. They needed the institution of slavery to succeed. And so as a result, we're going to see a lot of people who have mental health issues. They called it, we're going to see a lot of insanity because of that. And of course, how we judge insanity is all based on our bell curve and our white male perspective. And so there were a lot of people who were put in institutions, and then they decided they needed to have segregated institutions. They couldn't have white people with Black people and do that. It was used as a tool of oppression. Women, we talk about how the whole idea of hysteria and how women were treated. Again, men deciding what a woman's emotional response should be to life. And the fact that abusive spouses would drop women off at places and leave them and go on and live their life. And there was no way getting out. Once you got in, there was no way getting out. This was true with our LGBT population as well. And up until 1973, they kept the language in the diagnostic manual that being LGBT was a disorder. And it wasn't until 1987 that language was fully taken out. Last legislative session, I had a person with lived experience say to me, it's like they don't want to see us. They just don't want to deal with us. They don't want to see us. And I thought, yeah, that's right. But what was interesting about that, too, is it reminded me of ugly laws. We used to have laws where people who were poor, disabled, who made us uncomfortable in any way, we could get rid of them, put them away in institutions, in jail, wherever, because they made us uncomfortable. And so and they did away with those actual laws. I mean, they went clear until 1974, which is hard to imagine, but they did. And that is, I think of that often. So are we in that spot now? Here are just some pictures. I mean, this is just not that long ago when these things were happening. So they started to do away with institutions. They were cruel and inhumane. They had newer medications that made it so people could live more fulfilling lives without having to be locked up. And of course, in the 1950s, they developed nursing homes and they saw, oh, here's private enterprise, a way that we could shift people over here, people can make money. It's not a federal government program. But the truth is, more psychiatric hospitals will not solve the mental health crisis. It will just put more people in hospitals. And that's the tipping point that we're at. There are people who really do think, oh, we need to get more people back into hospitals. So, another quick review of history. We look at religion, that didn't have answers. Demon possession, result of sin, lack of faith, weakness, you can't pray it away. But science didn't do much better. In fact, science did more damage. I'm not going to judge which is worse, but using various medications experimentally to treat mental illness, the use of restraint and seclusion, eugenics, and there was just an article in the Trib this past week on how we still have that. It has not been overturned, the Buck v. Bell case, where a young woman was found to be feeble-mindedness and people who were not socially appropriate. And she had forced sterilization. She lost her case, was forcefully sterilized. And I find it particularly interesting in this whole discussion about reproductive freedom and bodily autonomy. This is not a new concept, it's just taken on different shape through the years, but it's something that has repeatedly been used. Lobotomies. So the doctor who was a big purveyor of lobotomies won the Nobel Prize for that in 1949. And then there are electric shock therapies, psychosurgeries. These still continue, and they're highly controversial, and there are, depending on different experiences, it's still used, and I will just leave it at that. And the DSM-5, the diagnostic manual that issues diagnosis, but also payment, how we get insurance to pay, went through a huge crisis in 2013 where the National Institute of Mental Health and the American Psychiatric Association were at a conflict. And frankly, they were pathologizing everything. They were making it so any possible thing that any of us are dealing with had a mental illness attached to it. And there's concern about that. And more recently, the role of medications and serotonin. There's been some studies out recently that say chemical imbalance isn't really a thing. And so science does not have all the answers, just saying that. When we talk about policy, in 1963, John F. Kennedy, he was a champion of getting people out of institutions and into the community. And they had the Mental Health Centers Act of 1963. And he was a real champion. The problem is they didn't fully fund it the way they needed to, and they didn't think of year-over-year budgets. So it did not accomplish what they needed. In 1980, so Rosalind Carter was a huge mental health advocate. They had a presidential commission on mental health. They came up with a lot of recommendations and funding, and it was seen as landmark legislation. And then Reagan came in, and through his omnibus budget, Reconciliation Act wiped out this legislation that had taken years to get built and passed. And it put, again, the concern was, oh, we need to make the states in charge of this, take the federal government out of it. They put the money on a block grant, and they cut the budget by more than 25%. And that's how things have been. So it's really heartbreaking, and I know this history, but I was going through and rereading what could have been, and it's hard. Now, the Americans with Disabilities Act was a huge thing as far as helping people with disabilities have protections and live in the community without discrimination. The Olmstead decision, Supreme Court decision, written by Ruth Bader Ginsburg, might add, and it was about getting people out of institutions in the community where it's possible, and having people in the least restrictive environment as possible. So today, we have our Utah State Legislature, and there have been some really good things with crisis systems that have been developed. There's a 988 number that people can call that, is hopefully taking law enforcement out of that response where possible. However, there are a lot of concerns around this for people with lived experience as far as confidentiality. Can they track me? Is my name on a list? And there's a lot of education that needs to be done as far as that goes. This past session, there was a focus on involuntary commitment, and this continues. There was a bill that made it easier to commit people. It lowered the standard to which someone could be civilly committed, and it put the time that someone could be on a psychiatric hold from 24 to 72 hours. So if you go inpatient, you have a minimum of 3 days in there for that assessment. And maybe that's good. I can see some advantages to that. However, a lot of times nothing changes. If you're there for 3 days or a week or 2 weeks, when you come out, nothing about your life has fundamentally changed. Hopefully you have some stability, maybe some medications, and a referral to a community provider. But things really don't fundamentally change. And what's interesting about this, the rate of suicide after hospitalization skyrockets. And there's multiple studies to show the first month, 3 months, year, and then years to come, it puts you at higher risk. And so, we shouldn't be so cavalier about that, about putting people in a hospital, even if it's not a long-term institution. Hospitalization has mixed reviews for sure. They keep people safe for a time, and that can be very important and help them to, gather information and be able to provide some initial treatment, but it's not the long-term answer. Also, by putting someone for one night in a psych unit, we can pay for a month's rent. We can pay for a month's treatment of an intensive community outreach program, evidence-based model. I'll talk about that some more, for a month, for one night in a psych unit. But right now, just going from 24 to 72 hours, that's tripled our, even if there are no additional days, that's tripled our use of inpatient hospitalization and tripled our cost with finite Medicaid dollars. There was also a bill that made it so physician assistants could civilly commit people without having the training. Right now there's a designated examiner training, master level clinicians are making those decisions. And this, just like that, made it so physician assistants can make that call. And then there was a bill, this one was defeated, to create a commitment standard for those who are criminally involved. And part of it was to make mental health professionals responsible to limit travel of the people, keep them in their homes. And there's a big thing, that's a big trend too, is conflating the role of mental health professional and law enforcement. And it's very concerning because that crisis of trust issue, you need to be able to talk to someone and know that there is not a conflation of roles. Now, we received a lot of money for COVID relief and was spent in different ways. One of the concerns is, did it really trickle down to people? And there was an appropriation for $90 million for a research unit at the University of Utah for mental illness, and $65 million of philanthropic donations attached to that as well. And that will come online in 5 years for research, academics. And maybe that's I'm all for research, I get that. But we have a crisis right now, and there are people who need relief from COVID who have been displaced and have not been helped right now. So that's a policy choice. That's a decision that was made. Now, alternatives to institutionalization: assertive community treatment team, multidisciplinary team that goes to people's homes. They provide 24/7 care to people. It has a psychiatrist, therapist, peer, substance use professional, voc rehab, and they are available to the person. Intensive case management, probably one of the most important things that we could do that is underutilized. Peer support, as far as having people with lived experience helping other people. Prioritizing individuals experiencing homelessness and exiting higher levels of care like prison or the state hospital. They should not be an afterthought. They should be at the top of our priority list. The interventions that we have, the crisis interventions, need to truly be voluntary, confidential, non-coercive. And we need to create housing. And that is fundamental. If we care about people with mental illness living in the community, they need a place to live. So there are a lot of barriers to effective treatment. In the interest of time, I'll just say it's hard. It's easier to institutionalize people than to have teams go in the community doing that work. That right now there are issues with low wages, workforce shortages. That's certainly a thing. And there's a lack of accountability. Do we know if the services work? We're spending more money than ever in our mental health system, which is a great thing. Are we getting better? Are things better for us? So, housing. I am a mental health advocate, and I am a housing advocate, and we have to get this done. And this is a choice. We make a choice to not build housing. There is a basic hierarchy of needs. You all know Maslow's hierarchy, and this is how it applies. We cannot expect people to live with mental illness, take their medications when they're living on the street. It's just not going to happen. And we had a program where people had the assertive community treatment team. We were getting great outcomes, and we looked at it and said, what's happening? How come they're not doing well? And it was those who were not housed did not get the same outcomes. It's not shocking, right? We all know this, and yet it's a real thing. We need housing first. People are housed, and too often there are attitudes of, oh, so they can have bad behavior and they get housing. No, we're not doing that. And that's a problem, because then we have encampments, which nobody likes and is so dreadfully cruel to people. But there's only one way out of that, and that's housing. Housing requirements are for the chronically homeless. And if someone's been in the state hospital, jail, prison, a nursing home, or treatment for 90 days or more, they're not considered chronically homeless, and therefore are not prioritized for housing. We cut out the most vulnerable amongst us. That's a choice. We can say that we're going to put more money into our housing for people at risk of homelessness. But so far, the housing projects that have been developed have been outside of the typical housing budgets. There have been tax credit programs. There's some great projects that have been built in Salt Lake. And that's really important, but there are real issues with that. Criminal histories. Where do people go when they're re-entering from the jail, prison, or state hospital who have criminal backgrounds? NIMBYism continues to be a thing, not in my backyard. Yeah, I care so much. I care about these people, but I don't want them in my neighborhood. And look, I get it. It's hard. I understand. But people need to have a place to live. So how can we find good solutions to that? Not just in Salt Lake, but throughout the state. We have got to have options for people everywhere. And again, case management is the key to make that happen. So criminal justice system, we could spend a whole bunch of time on that, but specialty courts, reentry, training law enforcement to effectively deal with mental health issues. We don't have that statewide. We don't have that in Salt Lake. We need to be developing crisis response that does not include law enforcement, where mental health providers, and we have that with the crisis systems that have been built with mobile crisis outreach teams, but there aren't enough of them, and they just can't get there. So now what? The social determinants of health. This is where we're talking about what's really going on. What do people really need? And again, going back to Maslow's hierarchy, where people need safe places to live, they need education and literacy, they need social supports and coping skills that many of us take for granted because we have those. When we're in trouble, we know who we call. But some people simply don't have someone to call. So there are a lot of things that need to happen that are just common sense. It's what we all want. It's not that this special population wants something unique. They need nutritious food, exercise, sleep, relationships, social connection, a sense of community, transportation, housing, and meaningful paid or volunteer activities. And that all contributes to good mental health, and that's what we all want. Finally, I'm going to say we need to listen, well, two things. The people we need to listen to, younger generation, that, they're saying, I don't see a future. It looks grim. We've had a global pandemic, poverty, wages are low, I can't afford housing, I can't afford rent, I will never be able to buy a house, I can't afford health care, I can't afford my mobile phone. Climate change is a gut punch, and it makes it really hard for people to feel hopeful about the future. And then a lack of leadership. Frankly, the young people look at our leaders and are just like, really? You're not giving me hope. And so it does create a real sense of nihilism, and it's real, and it does for all of us, but I worry about young people who need to have hope for the future and that we are raising up to be leaders. And finally, again, I'll say, listening to those with lived expertise. Peer support in all levels of care. We know if we have people with lived experience in hospitals, there is a reduced use of restraint and seclusion. We know it's an evidence-based service, again, that people do better when they have someone who's not an authority, who can put them in the hospital, talking to them, helping them, working with them on their goals. We need to provide safe spaces for people. And we need to let people drive their own care, focus on individual needs. When we look at, what are we going to do with people experiencing homelessness? It seems overwhelming. When we talk to people individually about what their barriers are, most of them we can find ways to figure out, we can work around. And we need to invite people with lived experience to drive policy at all levels. Finally, I'm going to end with a quote from Dr. Sachs, who is an attorney, PhD in neuroscience or something, and a woman with schizophrenia. She says, if you're walking on a path thick with brambles and rocks, a path that abruptly twists and turns, it's easy to get lost or tired or discouraged. You might be tempted to give up entirely, but if a kind and patient person comes along and takes your hand saying, I see you're having a hard time here, follow me, I'll help you find your way, The path becomes manageable, the journey less frightening. And I think we're going to do the plate, and then we'll have time for questions.
Thank you so much, Sherri. That was great. Yeah, we're going to pass the collection plate, and if I could have somebody on each side go up and down and collect the money. And then also in the back of your pews, there's a card like this with a QR code on it. You can donate electronically, or you can just go to your phone and Google SLCUU, and that'll bring you right to the church website, and there's a donate button there. So please give generously. We have to pay Tristan on our camera and microphone and all that, and we just need support to show the church that people appreciate these summer forum programs. This is the last program in our regular series. I might as well mention it now so I don't, well, I'll mention it later. We are going to have one more program about the Utah legislature, but I'll mention that at the end. So meet your neighbor. If we pass the collection plate, that'd be great. And then we'll have a Q&A session of about 15 minutes or so. So be ready with your questions. Thanks so much.
All right, we'll go ahead and do questions, and Venis is happy to answer questions too, she said, so.
Sherri, thank you. Thank you. I have an observation and a question. Observation is this is a national problem. It's not local with Utah.
Right.
January 8th, 2011, Tucson, Arizona, Gabby Giffords, Saturday morning. She's amazing that she survived. A federal judge didn't. Individual who committed that crime ended up in prison, not in a state hospital. 4 months later, in May of 2011, I'm on Capitol Hill meeting with our 6 members of Congress. I have one student who's going to get her master's eventually in social work, focus on mental illness. She asked the same question of our 2 senators, 4 representatives, about federal dollars to coordinate problem solution here. The 5 Republicans said that is not a federal issue. Jim Matheson, the Democrat, said, yes, this is something that's national. The 5 Republicans said that this is something that families should take care of, or nonprofits, or religious communities should take care of, but not the federal government. So then I transitioned back to Utah. I've talked to the state director of prisons, the Salt Lake County sheriff. They said that the state prisons and jails are custodial institutions, and they are the mental health facilities. So then I turn around and say, and the question now is, in the state legislature, who are our friends? Who are the people who are the sponsors of these bills, either for or against? They're trying to deal with the obvious problem with solutions that we must acknowledge and try to handle.
Yeah, I mean, it's a mixed bag. We have friends who are friends on certain parts of the equation and not on other parts. As far as having someone who's a true champion for people, the people living with illness, with mental illness, that's hard to say. And I think, again, very well-intentioned members, very well-intentioned people, but the solutions that are being offered tend to help the institutions. They increase budgets, of private providers primarily, and they just tend to be more punitive in nature, as far as we've just really got to put our thumb on this person, not looking at all the failures of the system that have happened. So we've got people who are great champions of a lot of different pieces, but as far as really looking at how do we support people long-term in the community, looking beyond hospitalization, looking at helping people live a life. And this goes not just for people with mental illness, but people with disabilities. We are just really behind in creating a world that offers life outside of institutions for people.
I really appreciate your presentation. I do quite a amount of volunteering at the in-between. Are you acquainted with the
I love them,
in-between?
yeah. Mm-hmm.
And I've been impressed on many of the things you've talked about. That program kind of speaks to all of that. When they first built their building and started there in the neighborhood not too far from here, people that lived around were a little uncomfortable with it. Do we want to have those kind of people
Right.
here? But as I look at the in-between and how it provides a resource for people who you may or may not call them mental health. They're just in need of housing and in need of a way that they can get their medical treatment done. And then also it provides a hospice service. I'm not quite sure where their funding comes from, but and maybe you could tell me more about that, but I'm amazed with the job it does of providing services that people need and helping them become independent.
Right. So yeah, for those of you who don't know, the In-Between is a program that provides hospice care for people. Really, it's designed to help people die with dignity, and gets people off the street, provides care, compassion for them at that time. But they also have people who beat the odds, and they guess what happens when people are treated with kindness, compassion? They get some food, they get some rest, they rally, they do well. And so they were saying, now we need to know where can we help people live in the community? So yeah, we need more places like that. That's something that Venis and I and some others are working on, to have a drop-in center for people with lived experience and families to come in, get support, get peer support, which is that actual practice, that service. It won't be clinical, and it's completely voluntary and just a safe space. We need safe spaces for people that they know they can go to, they can get support, they can get social connection. Again, a lesson from COVID, that isolation is devastating. And for people with serious mental illness, they have a hard time making those connections in those communities. And so we want to help provide, not make it all clinical and mental health, but just fun activities to be a part of. So I think it's a great model.
So Sherri, I've been reading about our troubled youth ending up in these for-profit, places where they are abused. Can you tell us how these youth get there and what's going on and how we can make it better for them?
So if I could do a whole several hours on this topic, this is something I feel so strongly about. It's very concerning to me. Utah's home to 1/3 of the for-profit facilities where children and youth are placed in the country. And it's because they're highly unregulated in Utah. It can come to Utah, and the Tribune, KUER, has done some tremendous reporting on this. And again, when you talk to the people who have lived it, who have been there, it's amazing what you'll find out. And we can find out, are these places we want to send our children and youth? And I understand desperate parents who feel like they have no other options. But that's where, if we could have, so there's wraparound for families, where you have providers, a team, And again, a peer, family peer who goes into homes, who works with the family to help keep the child in the home. Keeping people in their homes and communities is critical to their overall well-being. And even if people do well in institutions, a lot of times they learn to exist, they learn how to conduct themselves within the rules of that game, but once they come out to the real world, does it transfer? It's a real problem. But I would encourage you to do some research through our local reporting, which has been just fabulous on this, and find out. There are a lot of serious concerns, and again, children dying, terrible abuse, things happening. So, yeah, I feel, and I wanted to put that in there in this presentation. I thought, but if I do that, I'm going to go off on that whole tangent because it's such a big topic in and of itself.
Okay. Tristan says we have somebody on Zoom that wants to ask a question.
Yeah, we've got a question here from Jim Catano. He asks, what's the most compassionate and effective way to relate to the mentally ill and substance abusive when they're panhandling? And why wouldn't they be better off in a mandatory, well-equipped, well-staffed, and properly directed inpatient facility?
Yeah, those are really good questions. So I first of all will say there are so many groups that do a lot of good work with individuals experiencing homelessness, make donations there. I think as far as how you deal with individuals, that's frankly up to you on what you think. I'm never going to say to someone, you can't be compassionate or give to someone. So there's that. I think the issue of living in an institution it's about freedom, right? It's about freedom. It's about the fact that one of the reasons why our institutions devolved like they did was because they were not appropriately funded either. They were, it started off with a good vision and then they were not appropriately funded. And there are so many people. Why do we want to say this is all we think we're making that decision? This is all we think you can do. This is where your life is cut off. I mean, Venis would have been a prime candidate to be institutionalized for life. And that's why she feels so, I don't want to speak for you, but you've told me this before, that you feel so strongly about this, that give people a chance, give them a shot. And I appreciate our state hospital, that it's there, people are there, but it's not a long-term solution, and they don't want it to be. It's about getting people help, but then we need a place for them to come to in the community that has services and supports on site to help them. So there are ways to keep people in the community with services and supports that are not locked down institutions.
As someone who's on the autistic spectrum, my big question is in regards to mental health, why can't this be repositioned as a situation where you're dealing with a disability and thereby using the Americans with Disabilities Act, be able to get people the help they need, the supports that they need, and ultimately be able to integrate folks into mainstream of society.
It absolutely should be. Absolutely. People, if they are disabled by a mental illness, should be able to have all the rights and privileges under that act. And then, again, the Olmstead decision, it was a landmark case, and yet the promise of Olmstead that people can live in less restrictive environments has not been fulfilled. We have a long way to go on ensuring that people have a place in our communities and that we make space for them. But absolutely, they should get all the rights and privileges.
Okay, I have a question. With the people downtown that are panhandling, to what extent are social service people talking to them and getting to know their particular needs so that help can be delivered. And then secondly, if you were king, how would you handle the homeless? How would you provide affordable shelter for people at a reasonable cost? Because the numbers run up really fast. I mean, one possibility would be to use older RVs at a location supervised and that kind of thing. So
there are outreach efforts that are made to the extent that they're mental health driven, as far as being able to offer mental health services. That's limited, and it needs to be a priority of our system, that this population is prioritized.
do we keep a database on those people at all to help them?
Most of them are in a data system, but again, it becomes very difficult to provide good treatment if someone isn't housed. And it's hard to track someone down from place to place where they go. Medicaid does not reimburse for tracking people down. It's direct service. And so there are some real gaps in our system as far our payer plans as far as that goes. But just the reality, people get meds, they get stolen, they get lost. And if they have side effects, I wanted to mention that, one of the things people talk about, why don't they stay on their medication? Oh, when they went off their meds. Well, yeah, if you're put on a medication that makes you gain 50 pounds, that you can't think clearly, you can't use your brain, you're sedated, there's sexual side effects. I mean, do you all want to sign up for that drug? So we have to be compassionate about understanding that barrier. But also, the way people find other meds that work for them is by having a long-term relationship with a doctor who can help walk them through that, and they try things, they work together on that. And that's very hard to do when people are in and out of shelters and living on the street. So the answer, permanent supportive housing. This is the answer.
Okay, that was my second question.
We have a couple of great projects in Salt Lake City and for this population, and it really is. It's people live independently, they have their own apartment, they can come and go as they please, but it's safe and secure, and they get treatment coming to them through our ACT team. Treatment goes to them, and they get that. It's the highest level of community-based care.
But is there enough of it?
No, that's the issue, and that's where having mental health and housing budgets are separate, and so we need more developers to be looking at deeply affordable housing for people with serious mental illness, and then we need to be able to attach the services to it. We've done it. It's not impossible. It's a heavy lift.
But what about RVs? That's much more affordable, I would think, and then it's flexible.
Yeah, I mean, look, I think with housing, there's not a one-size-fits-all for everyone, that there are different options we can look at. But again, it's very hard to have a community-type living in an RV, so.
Hi, thank you, Sherri. You're amazing. Thank you so much for your incredible work. And thank you, Venis, also for coming and sharing your story. Here's a question for you. Recently, the Front of the Tribune has talked about Rocky Anderson saying he's going to possibly run against Aaron Mendenthal, predominantly around the issue of homelessness. Would you care to comment on that?
Well, I don't really know what all of his solutions are. So to me, the devil's in the details, right? I want to hear, so what are you going to do differently as far as that goes? And, ultimately, again, I'm going to say we have COVID dollars, still unspent COVID dollars. We have to just invest in housing. There is no shortcut around this problem. We can talk about all sorts of different different ways. And there are some policies that can be changed that would help that for sure. There are issues around eviction that can certainly be addressed. So yes, there are things that we need to do, but it really comes down to housing. I don't care how we talk about it, and it can't be a Salt Lake City problem because it's not a Salt Lake City problem. It has to be the state takes a full interest in this. There's been some good movement on this. Senator Andrick has been a champion for housing. There's been movement on this, but the funding still has not followed like it needs to.
Okay, I think is there another one? Okay.
Yeah, we've got a couple comments and a question from Zoom. Kathy Adams comments, as a retired licensed clinical social worker, I have seen Salt Lake go from a funded, well-managed system for the mentally ill to a private, poorly managed system. Salt Lake was number 3 in the nation for services for the mentally ill. E. Fuller Torrey wrote a book, Surviving Schizophrenia, which lists all of the necessary services. Unlike people with HIV who have money and an organized support system, the mentally ill have next to nothing. It is a matter of funding and social support. Liz Waite comments, I agree with Tim and Sherri's points about the sidetracking and tentative types of legislative support for unsheltered and mentally ill. There's a real attitude about worthiness and one's own record of accomplishment or sincere attempt, a judgment of who deserves help. We have a question from Sheldon Bradshaw who asks, what are your thoughts on R1 zoning / walkability? Yeah, that's
kind of going off.
There's one other question that if you want to take up this one. How can we support our transgender unsheltered and or criminal justice involvement that can't find beds due to discrimination, lack of beds, and threats of violence / sexual assault? Are there any efforts to have anti-discrimination laws for public accommodations in Utah? And are there any efforts for supportive housing for our transgender unsheltered family?
I am so concerned about that, and I wanted to mention that too as we look to the future. We can't say, oh, we've got great systems and crisis systems and we're doing all this work when simultaneously we have discriminatory laws against transgendered individuals or we see women losing rights, and all of that affects mental health. We can't do that and say, well, you can call our crisis line and hope that works out. We have to have concerted efforts to work to help different populations. So with our organization, our focus is on the marginalized communities and how we can provide what they need. I would love to talk with people who have ideas about what kind of housing would be appropriate, what they'd like to see, and for the LGBTQ and specifically trans population, what we can do to make that happen. But that's got to be a priority, especially in light of the ugliness that's out there towards this population. It is a crisis, and we're going to have to step up. And that's what makes it challenging too, is we have a marginalized population and then marginalized populations within that population, and very specific needs. And that's why I'm going to say again, we need all voices at the table, and it can't be a token person because sometimes they'll throw someone in there, but it's got to be people who know what it's like, to live their life and what they need to succeed. We need them at the table.
Okay, it looks like we have one last question. We've got to wrap this up.
Yes, how much of a factor in Salt Lake City would legacy zoning laws be in regards to providing affordable housing?
When we get into specific zoning, we need our housing experts to talk about that. But there certainly are different things. I mean, there are things that we can do as far as zoning is concerned to broaden our ability to offer permanent supportive housing, for instance. And I know they're looking at how they can revamp things and make the process not so onerous, but we'll see what happens there. But I'm just going to say, again, this is a civil rights issue of our time as we're looking at other populations who seem to be losing rights, being targeted. This population is as well, and we need to be aware of it and resist the urge to lock people up. We can't afford it anyway. I'm going to say again, with mental health, you can serve so many more people at a fraction of the cost by providing home and community-based services for them. So, and you get wonderful people to bless your lives and be a part of your community. So, thank you.
Okay, thank you, Sherri. Thanks, everybody, for coming. This is the final summer forum in our regular series. Now, we do have one add-on program that we have pretty well put together. We're going to have Elizabeth Waite from our congregation, who's also a representative at the Utah legislature, and Suzanne Harrison, who was in the Utah legislature and is now running for Salt Lake County Council at-large position. And the topic is going to be the Utah legislature, what they do not teach you in civics class. So we're going to get into the details, and we might continue this conversation. We're trying to pin down the date. It's about a week out, and it's going to be in the evening. So we'll keep you posted. We're just trying to line it up with all our speakers. So thanks so much, Tristan, for your help on all these summer forums. And thanks to the Unitarian Church for allowing us to put this together. I think it's been a meaningful experience for our community and our congregation. And our belief as Unitarians is we want to do what we can while we're here on earth to make the world a better place. And I think these discussions like this are an attempt at moving us forward in that regard. So we can continue the conversation in Elliott Hall or on the patio. And thanks for your attendance. Thank you, Sherri. Have a good Sunday. Thank you. I was the coordinator for Summer Forum, but the heavy lifting was done by the team leads. But this is a format that I think our church could use going forward, is where you have a coordinator and then you have people be a team lead on whatever we want to do and then put together their team to make it happen. Thanks so much.